Thank you, Robert, and thank you to the IC for the opportunity to present today. I'm going to go relatively quickly because there's a fair amount that I want to try and cover. Those are the onesies that we give out to people who are having babies. So if anybody's pregnant, let me know and we will organise for an appropriately covered onesies. We have them in yellow for the gender neutral babies as well nowadays. I want to acknowledge the traditional custodians and pay my respects to the elders past and present. So these are my declarations, and as the bottom bit is probably the most important, I've received support from most of the vaccine industry participants in Australia. If there's any vaccine company that has not supported one of my research projects, please get in touch today so that the views expressed in the slides are my own. I want to talk about adjuvants, the journey, those in current use, the benefits, which I'm a real supporter of, and the risks, which I think are overdone at times. So adjuvants are constituents which improve immune responses to the antigen. It leads to a number of things. It leads to a reduction in the antigen amount, and it also increases stability, extends the half-life, and we've seen that with some of the vaccines we're using at the moment, as well as improving the power. So lots of these are available, and this is what they do. They give you a stronger, broader response. It often gives you the capacity to actually get some heterogeneic protection, and it lasts for a longer period of time than using non-adjuvanted vaccines. This is all complicated stuff about cytokines and interferon and so on, but I think the most important bit for the is that we end up getting a stronger adaptive immune response to the antigens, and that's obviously beneficial, as we've seen with greatly varying antigens over the last few years. This is why we need them. These are very clever organisms, viruses and bacteria. They have intracellular infections so that they get immune evasion. They have multiple serotypes. I've given up trying to count how many pneumococcal serotypes there are. They're like flu. They change halfway through the year. They have complex life cycles. Trying to get a malaria vaccine has been something we've been doing for forever without being able to do it. And then we have problems because children don't have a good immune system, the elderly don't have a good immune system, and people who take biologics or people who have other immune issues have problems. So in a way, this is demonstrated here by having normal vaccines, going to recruit the APCs, going to the lymph nodes and then producing some response. But with adjuvants, we manage to actually get lots of other things happening as well as the antigen presenting cells. We get cytokine involvement and we get a much more mature T cell response than we do with just giving the vaccines on their own. And so this is the history of it, and everybody would be aware that we've used aluminium for almost a century now as an adjuvant to try and get a better response. In the 1940s, there was something developed called Freund's adjuvant, which was actually the first oil in water emulsion that similar to the MF59 and some of the others, some of the ASOs that we use at the moment. It was so reactogenic and so dangerous that it's actually banned from being used in humans, although it is used in some animal studies and in some non-infectious products that they're around. After that, we had the arrival of bacterial lipopolysaccharides, and then in 1997, MF59, which was by its name the 59th product that Novartis tried in those days to link to a human influenza vaccine, used extensively in Europe, in vaccines for almost 30 years now, and then starting to be used in other countries in the late noughties. ASO4 was developed by one of the other companies and used in human papillomavirus and HPV. It was one of the disappointing aspects of technology that they had. One company had the adjuvant that made it last longer and was probably a little bit better, and the other company had the two serotypes that caused genital warts, and we ended up using the one that covered broader things instead of the one that worked better at that particular time. So from there, we've gone on to AS01, which I will cover today, which is different to some of these other ones. And then one that everybody's been associated with more recently, the lipid nanoparticles that have been used extensively in mRNA vaccines. So these are some of the adjuvants in current use. We still have aluminium in a number of our vaccines at the moment. We have MF59, which is used in the Fluad product that everybody over the age of 65 is getting, and welcome to one of those over 65s who's sneaking into the back of the room at the moment. Good to see you, Michael. And AS04, which is in HPV and hepatitis B, and down the bottom AS01, and I want to talk about it briefly. So the benefits of these, I want to use 3 examples for the benefits of current adjuvants. MF59 is an oil in water adjuvant. It actually increases recruitment of immune cells to the regional lymph nodes and produces a broader based B cell expansion and T cell activation. It's been around for about 30 years, and we've been using it in Australia since 2018, and was used in Canada when I was there way back in 2012. This is some of the body of evidence as to medical encounters, hospital encounters, and other hospitalisations and ER visits. These figures may look a little bit small when you look at them. We're talking about relative vaccine effectiveness. So this is not absolute. This is relative compared to placebo or compared to, unadjuvanted vaccine of 10 to 30% in different studies. But when you consider the burden of disease of something like influenza on a community, officially Australia gets lately about 250 to 300,000 cases. It underestimates the amount of influenza by, somewhere between a third and a doubling at least. And so what we're seeing is that this has an enormous impact on the actual impact of the virus in the community. And I remember seeing some work that was done by CDC in the US, and what they found was that there was about 86,000 hospitalizations saved if you could increase just by 5% the effectiveness of influenza vaccines. So this is a vaccine that isn't perfect, but is getting better with the use of adjuvants and with the use of cell-based technology and non-X and so on. This is some of the overall meta-analyses. Outpatient visits at the bottom, 40.7%, and hospitalizations, 58%. And I refer you to the 2 studies at the top on the left, which are obviously the seminal studies on ATIV. All right, and this to me was one of the great stories that came out of the introduction of this vaccine. So we had unadjuvanted vaccine in 2017, 250,000 cases. We had adjuvanted vaccine in 2019, 300,000 cases, lots of disease in the elderly, both H3 and 2 years. And what we saw was that hospitalizations decreased by 60% in this age group in 2019 compared to 17. And the reason being, and these data from Sheena, I don't know if she's still here today, showing that the best protection of any group in Australia in 2019 was for those 65 plus years of age. And that was because we used an adjuvanted vaccine in those and unadjuvanted in the younger age groups. And it's the first time I've ever seen data that says the response against H3N2 vaccine was better in the elderly than in any other group. So really, this is a sign that says adjuvants may not stop you getting the flu, but vaccines are not there to protect you getting infectious. They're there to protect you, maintain your functional capacity. And if we stop you going to hospital, you maintain your functional capacity, and that's what they're supposed to be doing. So That's a summary. I want to talk briefly about AS01, and there are some of my colleagues who believe that this is actually a step forward ahead of all of the other adjuvants that we're using at the moment, and that's based on some of the mouse studies that they're doing at the moment in New South Wales. It's different in that it's a liposome-based adjuvant, contains two immunostimulants that work together, and it produces a rapid response first at the injection site and the draining lymph nodes, but it actually leads to a much broader range of APCs, and that leads to enhanced protective immunity response. Now, I'm not going to try and make a case that says one adjuvant is better than the other. Usually they're not available in the same products anyhow, but this really looks like it's going to produce a better response than some of the other adjuvants that we've used in the past, mainly interferon-driven pathway, but an enhanced cellular response. And so we're seeing this, and this is one of the examples that what you're getting is not just the usual responses, but you're getting a release of chemokines which assist with the response. And so I want to talk quickly about two. One of these is called Shingrix, and this has the AS01 system with the glycoprotein E, and everybody will be aware of what a massive change it's made moving from a live zoster vaccine to this particular adjuvanted vaccine. Data suggesting that massive effectiveness early on, but even at the 10-year mark, we're still seeing high 70s with a protection at 10 years using Shingrix, and an overall, averaged efficacy of 89% over that period of time. The other one, and there's some information, I think, at the GSK stall here today about Arexvy. Arexvy is also using this AS01 adjuvant system, and it's producing incredibly good results in the elderly against RSV. And RSV in the elderly we're starting to recognise a very important condition, producing a lot of difficulties. So great vaccines. Obviously, we don't have the same degree of duration of protection information with Arexvy, but both of these using the AS01 system have very good protection and look like they'll last for a significant period of time. So these are lipid nanoparticles, and everybody would have heard a bit about this. We've started using mRNA technology, and the benefit of mRNA technology you saw particularly with the early doses against COVID-19, SARS-CoV-2. These are a mix of different lipids doing different stuff to stabilise and aid assistance into the cell and so on. They're not just a carrier. There are data that suggests that they produce a adjuvant impact which is broader than just the capacity of being a carrier to get them into the cells. Various studies have shown increased recruitment of T follicular helper cells and potent antigen-specific CD4 and CD8. So these are originally, I think, designed to actually get stability around our mRNA technology and get them to get into the cell and be effective, but they actually look like they have the additional benefit of having that. I don't think you can have a discussion about vaccines nowadays without talking about risks, because somebody will certainly talk about it. I think every TTS victim had about their own whole week's worth of media during the early stages of AstraZeneca vaccines. So these vaccines work better. These vaccines are more reactogenic if they have antigens in them. So does that matter? And that's what's the important bit. And so what happens is that with Shingrix and Arexvy, we get more local reactions. We also get more severe reactions, but these are almost always self-limiting, last a day or two, largely focused on local issues. And I think in the end, the absence of very severe problems, and I'm not going to talk about Asia syndrome today, but I'm happy to chat to people in the break about where I think that is. MF59 the same. greater number of local adverse events, particularly pain. David Shifley's study in human immunotherapeutics 10 years ago looked at the at that stage, the intradermal, the adjuvanted and the non-adjuvanted, and again, the pain was most important. But his study said 96% of the people would be happy to have the vaccine again the year after. So more pain. There was actually some data in the last week saying that there was a relationship between the pain and the benefit of the response, which is interesting. I always told my people for a while that it's good if they had a sore arm. It meant that the vaccine was working well. I stopped doing that when the people who didn't get a sore arm rang me up to say that they didn't think the vaccine was working. So this is Omicron. The benefit risk value, and this is a study in the American Journal of Epidemiology last year, and it said the benefits of these vaccines far outweighed the 1 in 100,000 myocarditis or various other things. And so while Australia is very conservative in not letting children have vaccine and so on, I think the overall risk benefit of adjuvants has been huge over the last decade, and I look forward to the continued development of that. So, summary, a range of new adjuvants have led to improved vaccines. While there's increased reactogenicity, the risk benefit heavily favours vaccination, and we should preferentially use these newer vaccines as they become available. I hope I didn't go too far over. Oh.
Questions? Pretty surely.
Oh, did I really? No.
Right. More people are coming. So which one of these vaccines have you had, Paul?
I've had every one. Yeah.
You're protected.
And in fact, I cheated. I've had MF59 vaccine since the phase 4 studies we did in 2012. And so I've always managed to get myself the over 65 one, even though clearly I'm nowhere near 65 years of age.
Hello. My question is co-administration of vaccines with adjuvants, so Fluad, Quad and Shingrix. Yes, no, why not?
There are no safety data that makes me worried about doing that. And so there was a message that came out of some of the regulatory bodies that said, please avoid giving 2 adjuvanted vaccines at the same time. And I think that's probably still the official word. But the unofficial word is that if you have somebody that you're not convinced you're going to be able to get back a week later to give them the other adjuvanted vaccine, give them both at the same time. And so this is really a matter of when an older person turns up to see you, then if you don't think they'll come back, or if it's been a real effort to get them to clinic with their walker and all of the rest of it, then please give them all the vaccines they can have. I usually try and get 4 vaccines into my older people at the one time because I think that that's protective. This is not like 2 live vaccines or whatever. We're talking just about the fact that there's some uncertainty around 2 adjuvanted vaccines, but not based on any data that says it's unsafe.
Okay, thank you.
Seth.
Yes. Hi, Paul. Wonderful presentation. I'm Seth Toback. I work at Novavax, so full disclosure. And I see that we didn't get our name up on your first slide, so we have to talk about that afterwards because we were one of the companies that somehow.
The IC and I would be happy to talk about sponsorship afterwards.
Okay. But as a maker of a COVID-19 protein-based vaccine that's adjuvanted, I did want to mention that we probably have the most novel, newest adjuvant out there, the Matrix M, which is similar to your AS1, but it's got the 3 components: the saponin-based, phosphatidylcholine, and cholesterol, that makes it fairly unique. And I think we can probably get you some slides on that because it's the newest one being used in only currently 2 vaccines, our vaccine and the R21 vaccine for malaria. And I think that has had some unique features that have really boosted the malaria vaccines that were historically had very low efficacy. And one of the things that I wanted to comment about your slide, which is adjuvants equal increased reactogenicity. That's one of the things I think is unique about our vaccine. In fact, I presented on this at the last meeting. I had a poster in the back, and this has been seen in many trials that our vaccine has a lower reactogenicity profile than most of your other comparable vaccines, 40 to 60%. It's been seen in randomized trials. Peter Richmond's data from Peekaboo just showed that, the COV Boost trial from the UK. So I have lots of information. And you can ask me about it at the booth, but I just wanted to bring that up since it was a temporal topic.
Thank
So
you. And while there's, I want to discourage every other company from now getting up and having a chat about their vaccine. However, I think there is some uncertainty around some of this. I don't want people to feel every time that this does this. I spent a lot of time early on during the pandemic thinking about whether or not different lipid nanoparticles were responsible for different reactogenicity. I saw some data this week about the self-amplifying mRNA that's being studied by one of the companies. And in fact, they had lower reactogenicity with that one, even though they had a better response than they had with their previous one. So part of that probably relates to the fact that they have 5 micrograms because it's self-amplifying instead of 100 micrograms. And so maybe the RNA the mRNA is more important than the lipid nanoparticle in the reactogenicity. I think the message I'm trying to give is these vaccines are better. Please use them. We can manage reactogenicity so long as we're open about potential side effects with patients when we see them, and that we understand that maybe we need to be cautious in some groups.
So I've got a bunch of questions online that can try and cover them quickly. Although better for the over 65s, adjuvanted vaccines seem more effective and longer lasting. Why not use them in everyone?
Absolutely, I agree. And, you know, if we talk about MF59, there was a study about 15 years ago by Timo Vesicari in children showing that it was 86% effective adjuvanted in children, 43% effective unadjuvanted, licensed in Canada, not used anywhere around the world. We should be using adjuvanted flu vaccine for everybody. And I give it to all my family, irrespective of their age. Don't quote me.
Hazel Collier, in one of her talks yesterday, looked at the issue of Guillain-Barré syndrome and Shingrix. What is the association and risk with Shingrix? Guillain-Barré.
Okay, so there's a whole issue to do with these Guillain-Barré type syndromes, to do with autoimmune syndromes and all of the rest of it. I'm not sure that we have any information that says, you know, we can convincingly attract certain rates to certain vaccines with any great confidence. That we know that there are problems with some of these. The other AS01 vaccine, the Arexvy, had some signals also in the original data that was looked at by ACIP and the other regulators. And in fact, it led to a fairly lukewarm recommendation from ACIP saying that if you didn't have other conditions and you were 60 to 75, you should talk to your doctor about it rather than just recommending you went out and got an adjuvanted RSV vaccine. So I think this is stuff that we continue to look at. Often we don't have really good information until after we start using this product, because, you know, if this is something that's going to occur 1 in 100,000 or 500,000 or something, there's no phase 3 study that's going to give us information about this. We continue to monitor. Sometimes we have to vary what's going on. I don't know of a single condition that produces less Guillain-Barré or other constellation of autoimmune diseases, that it doesn't do it more often than the vaccine associated with that condition. So it's still safer to have vaccine than have the disease, but this is continuously being monitored because we do understand that people are concerned about it.
One more fairly difficult question for you, from John Macarunas. What is the situation with immune suppressed patients? For example, someone with a B-cell lymphoma who's had CAR T therapy and has had no B cells as a consequence. Do the vaccines produce an adequate immune response? And if not, how do you get around it?
Look, I think everybody recognises that people who are immune suppressed, whether they're quite as complicated as that, are increasing in number, you know, and some of the stuff we're using, like JAK inhibitors now, are actually worse than methotrexate, the things that we used earlier on. In my day, I think we used to inject them with gold or something or other for their rheumatoid diseases. So we have lots and lots of people. My recommendation to everybody in the audience is we should not give up on trying to get them protected against diseases. I never give the vaccine for somebody in that situation without talking to their consultant, rheumatologist or immunologist or whatever. And so they need vaccine. Sometimes they need more vaccine than people who have a good immune system. But part of that process is to find out with their immunologist, is there a good time to give them the vaccine in the midst of their treatment that would actually maximise their response? So should I give it immediately before they have their next injection of methotrexate? Should I give it right after the injection and so on? So I don't know the answer to those questions. I can get the answer to those questions from their specialist. Please don't avoid giving immune suppressed people vaccine. They need it more than those with a good immune system. Please consult with the specialist and give it at the right time.
Please thank Paul again.